Hello everyone, welcome back. Today we'll discuss about hematology and oncology. Most of the time, whenever there is a hematology question, you'll have to understand two important rules. We talk about coagulation pathway, but please do remember the coagulation pathway in extrinsic mechanism or extrinsic pathway is usually stimulated by extrinsic pathway is usually stimulated by endothelial injury and trauma. These are the two most important things you will have to remember for USMLE step 2. Whenever you find that there is endothelial injury, it is basically the activation of the tissue factor which causes the activation of the 7A. This is one important thing you'll have to remember. This is coagulation pathway. There can also be questions based on the direct inhibitor of 10A. What is it? It is apixaban, it is rivaroxaban, it is fondaparinux, as well direct thrombin inhibitors or argatroban, bivalirudin, and dabigatran. I'm telling you this because patients with atrial fibrillation and stroke are treated with apixaban, or patient who is basically got cancer and DVT management, it basically is given dalteparin or rivaroxaban or apixaban. This is one important thing you'll have to remember. Next, we talk about the hematology, proper hematology. Whenever there is proper hematology, it is usually the normal RBC picture. This is how a normal RBC scan is. All right. We will talk about the iron deficiency anemia, where there can be microcytic hypochromic picture, which you are seeing. Sideroblastic anemia, there can be granules around the RBC, that is sideroblastic anemia. Spherocytosis, neat, nice, round. Given that if the patient has got spherocytosis, the examiner must give you MCHC, because this is one important question where you can easily score and you can also save time. If MCHC is increased, it is hereditary spherocytosis or spherocytosis until otherwise proved. Now we talk about differentials of microcytic anemia. Whenever there is microcytic anemia,
Sorry, Linda wants to join. She said, can you please let her in?
so talking about the proper hematology, we'll discuss differentials of microcytic anemia. Obviously, the MCV is usually less than 90 if it is microcytic anemia. I would like to tell you that iron deficiency anemia, anemia of chronic disease, thalassemia, and sideroblastic anemia are the four most important causes of microcytic anemia. We will discuss them in detail. In iron deficiency anemia, we already discussed if the patient is an elderly patient with iron deficiency anemia, it is cancer until otherwise proved. If the patient is a young patient with iron deficiency anemia or microcytic anemia, it is celiac disease until otherwise proved, please. These are the questions the examiner can ask you. Next, we talk about anemia of chronic disease. Any chronic disease, any underlying chronic disease, there will be increased ferritin in anemia of chronic disease because ferritin is an inflammatory marker. That is one important thing you'll have to remember. Ferritin is a marker of inflammation. In anemia of chronic disease, there will be a lot of inflammation going on. That is why there will be increased ferritin in anemia of chronic disease. In thalassemia, ferritin will be normal. In sideroblastic anemia, there will be normal ferritin as well. We'll now talk about each deficiency in detail. Iron deficiency anemia, usually blood loss with the chronic GI problems or gynecology problems in women. There will be lot of blood loss that is lost, so stored iron is lost. That is why ferritin is decreased. The total iron binding capacity is increased because the RBC craves. The iron is decreased, and the bone marrow biopsy is the best test for iron deficiency anemia. How do you treat it? It is the iron. When you give iron, you'll have to check the hemoglobin after 4 weeks. Yes, after 4 weeks, the hemoglobin is increased. What do you do? Continue iron for 3 months, because first 4 weeks there will be recovery phase. So do not stop the iron. very important follow up is colonoscopy, because there can be cancer or there can be GI loss or any other blood loss from the gut. Next, we talk about anemia of chronic disease. Any chronic inflammatory disease can cause anemia of chronic disease. Ferritin is an inflammatory marker. That is why there is increased ferritin. And the TIBC is decreased. Total iron binding capacity is decreased, and iron is also decreased. Bone marrow biopsy again is the best test. The treatment is you'll have to treat the underlying disorder. Sometimes in anemia of chronic disease, you can try erythropoietin place. Most of the times, anemia of chronic disease needs to be treated by treating the chronic disorder. Next, we talk about thalassemia. It is usually chromosome 16 or chromosome 11 deficiency. Alpha gene mutation usually leads to frame shift. Alpha chromosome 16 mutation is an alpha thalassemia, which is usually with frame shift mutation, and chromosome 11 is a beta deletion. That is what you'll have to remember for thalassemia. There will be normal ferritin. This is one thing the examiner can give you. Please do remember that ferritin, TIBC, and iron are normal. How do you diagnose it? It is hemoglobin electrophoresis that we usually do. If the patient has got a transfusion going on, multiple transfusion, there will be iron overload, there will be splenomegaly. So desferoxamine is one important thing you'll have to give for the treatment or for the transfusion related issues. Sideroblastic anemia, there can be multiple causes: lead deficiency, B6, genetic disorders, myelodysplasia, excess alcohol, and copper deficiency can also cause sideroblastic anemia. In sideroblastic anemia, there will be increased iron, but there will be normal ferritin and normal TIBC. When you do a bone marrow biopsy, there will be ringed sideroblasts, and treatment is you'll have to give B6 and also look for any malignancy. Please do remember this. All right. We now talk about the findings in microcytic anemia. What are the most important things we'll have to consider? As already discussed, iron deficiency anemia, it is usually the lab values we are discussing. Iron deficiency anemia, there will be decreased iron with the increased total binding capacity. Thalassemia, there will be normal lab values. Anemia of chronic disease, there will be increased ferritin. That is one important thing you will have to remember. Sideroblastic anemia, it is normal to high serum iron and also increased ferritin levels we usually see. Iron studies in microcytic anemia, this is what we usually discussed, but please do remember the transfer in saturation. Whenever iron deficiency is present, transfer in saturation is decreased. Thalassemia, transfer in saturation is increased. Anemia of chronic disease, transfer in saturation can be normal or decreased, but I want you to remember that ferritin is increased in anemia of chronic disease. This is one important thing you'll have to remember. Next, we talk about differential diagnosis of hemolytic anemia. How do you understand that the examiner is talking about hemolytic anemia? Obviously, there will be jaundice. And the examiner can tell you that the patient has got peripheral smear which shows cystocytes. Remember, if the patient is young and is from a Mediterranean descent, it is G6PD until otherwise proved, triggered by dapsone, triggered by oxidative stress. Remember, G6PD deficiency is an X-linked recessive disorder, but please do remember G6PD levels needs to be tested for the diagnosis of G6PD. But when do you test G6PD deficiency levels? It is usually weeks after attacks, especially 6 weeks after the initial attack, you'll have to check G6PD deficiency. Next, we talk about hereditary spherocytosis. Already we discussed if the patient has got increased MCHC, it is hereditary spherocytosis until otherwise proved. Do not waste your time. Increased MCHC is present with the jaundice and splenomegaly. It is hereditary spherocytosis, please. Best test is osmotic fragility and treatment is splenectomy. Next, we talk about autoimmune hemolysis. Autoimmune hemolysis, IgG and IgM. There will be different causes for each IgG and IgM. I'll tell you what are all the IgG causes. It is usually the drugs, medications. It is usually the association of rheumatology or rheumatoid arthritis and cancer. Whereas talking about IgM, it is usually all M's: mycoplasma and monoclonal gammopathy of unknown significance. This is one important thing you'll have to remember. All right. Autoimmune hemolysis, there can also be spirochetes, but the most important test you do is a Coombs test. How do you treat it? The examiner would love to ask about steroids, please. But most of the time, steroids are not asked. It is usually the best test what we do. It is Coombs test we usually do. Next, we talk about paroxysmal nocturnal hematuria. We already discussed about paroxysmal nocturnal hemoglobinuria in our previous lectures. What is the speciality of paroxysmal nocturnal hemoglobinuria? It can cause both venous plus arterial clots, or venous plus arterial thrombus, or there is thrombosis in both arteries and veins. What is the first most important thing you'll have to remember? It is early morning hematuria, which gives us the clue for paroxysmal nocturnal hemoglobinuria. There is a mutation, that is PIGA gene mutation, and there can also be CD55 association in paroxysmal nocturnal hemoglobinuria. So flow cytometry needs to be done, and steroids are the most important thing. Obviously, eculizumab is the treatment. How did I remember? E is the fifth word. It is associated with CD55. CD55, you'll need to treat it with eculizumab. Next, we talk about sickle cell disease. African American patient presenting with chronic pain is sickle cell crisis. Hemoglobin S polymerizes. That is why the patients usually develop sickle cell crisis. What is the best test? It is hemoglobin electrophoresis. What is the first step? You do a peripheral smear. How do you treat it is the question. Give him IV fluids and oxygen. The examiner will tell you this. IV fluids and oxygen. What is the next best step? It is the pain medications, please. What did I tell you? You'll have to make sure that the patient is comfortable in medicine. Make sure he's given adequate analgesia, then give blood transfusion or exchange transfusion. That is another important thing you'll have to remember, please. All right. This is how the sickle cell anemia peripheral smear is. This is G6PD by itself as well. Common causes of macrocytic anemia. Before talking about common causes of macrocytic anemia, I will have to tell you that the most important, the most important thing the examiner can ask you is full blood count. What is a full blood count that the examiner would be talking about? We all know that the examiner, every question has got a full blood count. We'll talk about it in detail. Okay, we'll talk about common cause of macrocytic anemia in a minute, but I'll tell you how to look at a full blood count. First important thing you obviously know is hemoglobin. They will tell you the hemoglobin. If hemoglobin is low, what is the thing? I'll have to consider it as anemia. There are different types of anemia. If it is increased hemoglobin, there is polycythemia. Again, there is polycythemia secondary to smoking, polycythemia secondary to dehydration. If there is anemia, you'll have to consider, is there any particular cause or not? Or is it taken by a dilutional arm, or is it taken by an arm that has been given the IV fluids? Because there can be dilutional anemia as well. That is one important thing you will have to remember. Next subset is WBC. Obviously, WBC is increased in infection, increased in cancer, and increased in leukemoid reaction. This is another thing you'll have to remember. Next, we talk about platelets. Platelets, you'll have to remember thrombocytopenia, thrombocythemia. Thrombocytopenia due to CKD, there can be normal blood count, normal count as well, but there is most of the times it is the functional platelet count, so platelet count can be normal. All right. Next, we talk about MCV. MCV is usually macrocytosis or microcytosis. Microcytosis, we already know that it is basically because of the thalassemia, iron deficiency, lead poisoning. Macrocytosis, it is usually multiple causes. It can be B12 deficiency, it can be thyroid deficiency, it can be folate deficiency, it can be alcohol deficiency, it can be secondary to medications, it can be secondary to cancers. All right. B12 deficiency is vegan. Thyroid disorders usually has got associated thyroid symptoms. Folate deficiency is usually alcohol, doesn't eat. Alcohol is excess alcohol. And medications such as phenytoin can cause macrocytic anemia. Next, we talk about after MCV, it is the PCV that we usually talk about. If the PCV is increased, you will have to consider it can be hemoconcentration. If it is diluted, it is hemodilution. This is one important thing again. All right. RBC usually tests the bone marrow function. If RBC is increased, it is nice. If everything is reduced, it is aplastic anemia. All right. MCHC, it is basically increased in spherocytosis. Mean corpuscular hemoglobin, iron deficiency anemia, classic, please. All right. Next, we talk about the neutrophils. Increased in infection. It is also increased in acute promyelocytic leukemia. Lymphocytes, again, it is increased in infection, but please do remember there is chronic lymphocytic leukemia as well. Monocytes, they can be increased 2 days after the infection. Please do remember this. Eosinophils, they are also increased in parasitic infections. That is one important clue the examiner can give you. Another favorite question to the examiner for eosinophils is patients with Addison's disease. We discussed this in endocrinology. Addison's disease, there will be eosinophilia. All right. This is what the examiner wants you to understand. Apart from this, there is this thing called red cell distribution width. What happens in red cell distribution width? It is usually seen in patients who have got iron deficiency anemia. There will be abnormal red cell distribution width that is seen in iron deficiency anemia. With this knowledge of full blood count assessment, we will now see all the causes. Coming back about the common causes of macrocytic anemia. Talking about the causes of macrocytic anemia, what are the things you will have to consider? Folate deficiency, we already discussed. Patient, alcohol patient not eating. Vitamin B12 deficiency, intrinsic factor abnormality, and also vegan diet. Myelodysplastic syndromes, patient usually is an elderly patient or more than 60 years old. Acute myeloid leukemias, it usually young patient or a middle-aged patient. Drug-induced is hydroxyurea and zidovudin. Also, phenytoin can cause it. Liver diseases, alcohol abuse, hypothyroidism. If the mean corpuscular volume is more than 100, you'll have to consider that this patient might be having macrocytosis, please. Please look at the questions. That is how you can understand that this patient might be alcoholic, this patient might be thyroid, this patient might be vitamin B12 deficiency. Next, we talk about the red cell transfusion threshold. Very easy. If it is less than 7 without symptoms generally indicated, 7 to 8 cardiac surgery, or patient with any other abnormalities, yes, 7 to 8 you will have to consider. 8 to 9 if it is symptomatic. More than 10 not generally indicated. The examiner would ask you this one, please. 7 to 8 hemoglobin, 7 to 8 gram per deciliter. Patient has got some other thing. What is the next best step? Please do transfuse the patient first. Make sure the patient is safe. Next, we talk about hereditary thrombophilia. Most of the times, whenever there is hereditary thrombophilia, factor V Leiden mutation is one important thing. Young patients presenting with bilateral pulmonary embolism, young patients presenting with DVTs, young patient presenting with stroke, you'll have to evaluate it for factor V Leiden mutation. Most of the times it is the white ethnicity. It is basically because of the activated protein C resistance where we usually see factor V Leiden mutation. Next, we talk about prothrombin mutation. In prothrombin mutation, there will be increased prothrombin levels, but rarely the examiner would ask you this question. Antithrombin deficiency, there can be antithrombin deficiency that is usually as antithrombin deficiency. Nephrotic syndrome, there can be antithrombin deficiency, please. Very important. Obviously, it is very rare inherited form. That is why the examiner would ask you antithrombin deficiency. in nephrotic syndrome causing pulmonary infarction or causing DVT or causing stroke. This is one important thing you'll have to remember. Protein C and protein S deficiency, it is basically causing the inactivation of factor 5A and factor 8A. Most of the times it is warfarin induced skin necrosis that happens in patients who have got protein C and protein S deficiency. All right. Next, we talk about acute intermittent porphyria. We already discussed this in infectious disorders and also gastrointestinal. I'll again tell you, if the patient has got abdominal pain or abdominal symptoms with neurological symptoms with rash, it is acute intermittent porphyria. If the patient has got abdominal pain with neurological symptoms or abdominal symptoms with neurological symptoms with no rash, it is lead poisoning, please. Obviously, this is autosomal dominant manifestations can possibly be because of the abdominal pain, peripheral neuropathy, neuropsychiatric things. The lab evaluation is basically with elevated urine and serum porphobilinogen, ALA porphyrin as well. The most important thing the examiner can ask you is glucose and heme is usually needed for the management, please. All right. Next, we talk about porphyria cutanea tarda. This is associated with hepatitis C. We already discussed this. All right. Next, we talk about polycythemia vera. Most famous question the examiner would love to ask you is Gais-Bock syndrome. Don't remember the name. Just remember how the syndrome is formed. It is basically pseudo increase in the RBC count. This actually happens after massive hemorrhage. We all think that it is polycythemia vera after massive hemorrhage. It is not. It is basically the concentration increases. That is why the RBC count appears as increased, or patient has got increased hemoglobin because of the massive hemorrhage or dehydration. Polycythemia vera, coming back to it, it is basically increase in the RBC count. Whenever the RBC count is increased, patient usually has got hyperviscosity syndromes. This is one important thing you'll have to remember. Hyperviscosity syndromes. So the patient usually presents with headache or transient blurring of vision with the hypertension. That is one important thing, please. But these are usually transient. This polycythemia vera is a myeloproliferative disorder. Obviously, examiner will tell you that the patient has got itching after warm bath. You'll have to remember that it is polycythemia vera. Most of the times, the examiner can also tell you that the patient has got polycythemia vera because of the non-functioning platelets. Transient neurological symptoms can be seen, such as blurring of vision and headache, or transient symptoms in upper limbs and lower limbs as well. These are all the symptoms of hyperviscosity. Please do remember, erythromyalgia is usually associated with polycythemia vera, which is basically the cyanosis of the hands and the feet, but associated with the pain. Very, very, very important, please. Most of the times, the examiner can tell you that the presentation of polycythemia vera is a Budd-Chiari syndrome, which we will discuss soon. All right. Remember, if you are doing polycythemia vera evaluation, I want you to understand that you have to find the increased hemoglobin in the question, and also there must be JAK2 mutation that is positive for you to confirm the diagnosis of polycythemia vera. Everything else, if there is no JAK2 mutation, everything else is bogus. Everything else is normal. It is not polycythemia, please. All right. What are the complications? Polycythemia vera, we already discussed in neurology as well. Polycythemia vera is another cause where you can find arterial plus venous thrombosis. Okay, very important, please. Another one is homocystinuria, or patient who has got paroxysmal nocturnal hemoglobinuria or heparin-induced thrombocytopenia. There can be thrombosis in both arteries and the veins. What are the complications associated with polycythemia vera is another question the examiner would ask you. The examiner would tell you that the patient is developing shortness of breath, rapidly worsening shortness of breath with worsening infections. What do you think of? The patient is developing myelofibrosis. This is what you'll have to remember in polycythemia vera. This is polycythemia vera. You can see multiple RBCs, please. Polycythemia vera is one thing. The complications are thrombosis and myelofibrosis and acute leukemia. Treatment is phlebotomy with hydroxyurea if there is increased risk of thrombus in patients with polycythemia vera. Next, we talk about Budd-Chiari syndrome. It is usually the thrombosis in the hepatic venous outflow associated with polycythemia vera. Sometimes this can be the earliest manifestation or initial manifestation of polycythemia vera. So, myeloproliferative disorder needs to be ruled out in Budd-Chiari syndrome. Malignancy needs to be ruled out, and oral contraceptive use or pregnancy needs to be ruled out in patients, in female patients, please. All right. What are the manifestations of Budd-Chiari syndrome? It is obviously acute abdominal pain with jaundice needs to be thought of. Budd-Chiari syndrome if there is thrombotic risk factors. Obviously, there can be prolonged INR and prolonged APTT with elevated transaminases. What are the subacute manifestations? There can be abdominal pain, hepatomegaly and splenomegaly with ascites, and there can be elevation of bilirubin or transaminases. Please do remember, it is basically thrombosis with abdominal pain is Budd-Chiari syndrome until otherwise proved on a background of malignancy, myeloproliferative disorder, and oral contraceptive use. Diagnosis: abdominal Doppler ultrasound needs to be done to find out the hepatic venous anastomosis, hepatic venous outflow obstruction, or there can be decreased venous outflow. Next, we talk about the investigations for underlying disorder. This is what the examiner would ask you. It is the JAK2 mutation along with the facial plethora or any JAK2 positivity or hypertension or transient visual disturbances is what you'll have to think of. Next, we talk about iron deficiency, anemia, and thalassemia. Whenever there is iron deficiency, anemia, and thalassemia, what did we discuss? Lab studies are usually normal in thalassemia. Everything else, MCV is decreased in all the things. Red cell distribution width is increased. That is what we discussed, but it will be normal in thalassemia. RBC count is also decreased in iron deficiency anemia, whereas in thalassemia, minor and major, it is usually normal, please. All right. Talking about the peripheral smear, it is microcytosis with hypochromia, and in thalassemia, there can be target cells that are seen. And what is best responsive to iron supplementation? It is iron deficiency anemia, where you can find increase in the hemoglobin. And when you do a hemoglobin electrophoresis, iron deficiency anemia, it will be normal hemoglobin. But in thalassemia, especially in beta thalassemia, there can be increased hemoglobin A2. All right. We talked about anemia of chronic disease, thalassemias. Please do remember, thalassemia, there is alpha thalassemia and there is also beta thalassemia. I'm not sure if I've put it on the next slide. Yes, beta thalassemia. Alpha thalassemia, there can be silent trait, HBH disease, and major. Major is fetus hydrops. Please do remember, the examiner can ask you this question in gynecology or obstetrics. We'll discuss more about major uh, thalassemia in fetal hydrops in obstetrics. Please do remember, I'll tell you some important things the examiner can ask you. The examiner, if he's talking about hemolysis, it is HBH disease. If the patient has got asymptomatic disease, it is silent carrier. Very rarely trait is usually asked, but please do remember, hemoglobin electrophoresis usually is positive in HBH disease and major fetus hydrops. This is what you'll have to remember, please. Next, we talk about beta thalassemia. There can be trait, there can be intermediate, there can be major. Please do remember that there is increased HbF in intermediate beta thalassemia, increased hemoglobin A2 in beta thalassemia trait, and in beta thalassemia major, there will be absent HbA and there can only be HbA2 and HbF that is present, please. All right. The symptoms are severe in beta thalassemia major and alpha thalassemia major. Next, we talk about sideroblastic anemia. We usually need to rule out malignancy. If there is sideroblastic anemia, there can be hypochromic and normochromic, but there can be basophilic stippling. This basophilic stippling is a step 1 question where there can be ribosomal precipitates that are usually seen in the RBC cytoplasm. How do you diagnose sideroblastic anemia? It is the iron studies. There will be increased serum iron, There will be decreased TIBC with bone marrow biopsy showing ringed sideroblasts, please. Very important. Where is basophilic stippling seen? Thalassemia, anemia of chronic disease, iron deficiency anemia, and lead poisoning. These are all the, sorry, not anemia of chronic disease, it is alcohol that we usually see. All right. Thalassemia, alcohol, iron deficiency anemia, and lead poisoning, sideroblastic anemia, or basophilic stippling can be seen, please. Folate deficiency due to alcohol, we already discussed that folate deficiency is basically because of not taking the food. That is one important thing, please. And also alcohol abusers usually have got impaired enterohepatic circulation, which inhibits the folate absorption. All right. Folate deficiency due to phenytoin. Usually whenever there is phenytoin question that is asked, the examiner will give you about the seizure history. And remember, folate deficiency secondary to phenytoin causes megaloblastic anemia because it impairs folate absorption in the jejunum, please. All right. Phenytoin usually has got gingival hyperplasia, so there can be increased gum size in patients who have got phenytoin abuse. Patients receiving phenytoin should be supplemented with folic acid and calcium and vitamin D. This has been recently asked question, please. All right, folic acid and calcium and vitamin D needs to be given in patients who are taking folate. All right. Next, we talk about the folate and vitamin B12 deficiency, especially if the patient has got alcohol and vegan diet. Combined alcohol and vegan diet, it usually causes both folate and vitamin B12 deficiency. Remember, most of the times, whenever there is folate and vitamin B12 deficiency, it is hematological malignancies or hematological findings with the neurological findings the patient develops. I would tell you that if there is any of the deficiencies, you'll have to correct both the deficiencies because it can possibly be, it can cause subacute combined degeneration of spinal cord if you only treat one disease, please. Next, we talk about anemia due to CKD or end stage renal disease. Patients usually with anemia or CKD is basically talking about anemia of chronic disease. He is got increased ferritin, please. This is one important thing you will have to remember. Most of the times in anemia of CKD, it is normochromic or normocytic anemia because of the decreased erythropoietin production. Whenever there is decreased erythropoietic production, what do you have to do? You will have to stimulate the erythropoietin production. That is why you can give erythropoietin directly, or you can also give erythropoietin stimulating agents such as darbepoetin. The examiner will tell you that the anemia of chronic disease have been treated with erythropoietin. What is the side effect? It is the seizures that is usually seen. All right. Next, we talk about in anemia of chronic disease, the examiner can also ask you about supplementation of erythropoietin, but the patient is not responding to supplementation of erythropoietin. What do you do? Whenever you are treating the patient with erythropoietin, please make sure that the iron supplementation is adequate. This is one important thing you'll have to remember. Iron supplementation needs to be adequate if you are thinking of erythropoietin supplementation and erythropoietin supplementation not resolving the anemia. You'll have to make sure that the iron stores are adequate before giving erythropoietin. What is the side effect of erythropoietin? It is usually the worsening hypertension, and patients can also have seizures, please. And erythropoietin is an orphan drug, please. All right. Next, we talk about hereditary hemorrhagic telangiectasia. Patient has got anemia with mucosal AV malformations. Patient usually presents with, or patient usually on examination, patient usually has got telangiectasia. There can be recurrent epistaxis, AV malformations, and patient presents with decreased hemoglobin or shortness of breath. It is usually autosomal dominant disorder, so there can be family history in the question. It's also called as Osler-Weber's-Rendu syndrome. Okay, I've written it here. Diffuse telangiectasia, recurrent epistaxis, AV malformations, which usually occur in mucous membrane, skin, and GAT, may also occur in liver, brain, and lung. Hereditary hemorrhagic telangiectasia usually can bleed spontaneously as well. Next, we talk about multiple myeloma. You all know that it is usually presenting with bone pain, worse at night, increased at night. Bone pain increased at night, presenting with fatigue and weight loss. You'll have to think of multiple myeloma if the CRAB features are fitting it. What is CRAB? Hypercalcemia, renal involvement, anemia, and bone pain. This is one thing you'll have to remember, please. All right. What are the features of multiple myeloma? It is usually the proliferation of the neoplastic cells that happens in the bone marrow. So the patient can present with normocytic anemia. Sometimes there can be lymphocytic population that is usually impaired. So there can be ineffective antibody production, and this can lead to hypogammaglobulinemia, and it can lead to increased infections. Please do remember, whenever there is increased infections, it is usually the upper respiratory tract infection, or it can possibly be because of the UTIs that the examiner can be talking about. On the X-ray, you will find that there is lytic bone lesion. All right. Here comes the important point. Whenever there is an excessive production of immunoglobulins, it is usually the single immunoglobulin that is usually seen. So there can be monoclonal protein, or M spike is usually seen, that accumulates in the renal tubules and can cause renal insufficiency. Protein gap is more than 4 grams. How do you calculate the protein gap? It is total protein minus albumin. Please do Please to remember that the examiner usually will not give the protein gap is more than 4 gram. The examiner will give you that the total protein is so and so, albumin is so and so. You will have to calculate the protein gap. How do you calculate the protein gap? It is total protein minus albumin, which gives you the globulin. All right, this is what you'll have to remember while solving questions in patients with multiple myeloma, please. All right, when you do a urine analysis, it is usually the light chains that we usually see in urine analysis, please. Very, very, very important, but the examiner would not be asking about this. Peripheral smear, there can be Rolex formation and leukopenia. Here comes the most important thing. How do you screen the patients? It is the serum urine electrophoresis. It is a screening test. Please do remember, it is not a confirmatory test. The examiner, if they want to ask a confirmatory test, it is usually the bone marrow biopsy with more than 10% of the clonal plasma cells. That is what the examiner would tell you, please. Clonal plasma cells of more than 10% is a confirmatory test, whereas a screening test, it is the serum urine protein electrophoresis and peripheral smear, which shows Rolex formation, or serum free light chain or Benz-Jones proteins are usually seen as a screening test, please. But the confirmatory, there must be more than 10% of the clonal plasma cells. Everything else, all the clinical stuff, everything else, this is what you'll have to concentrate. It is the screening test, that is serum urine protein electrophoresis, or peripheral smear, which shows Role formation, or serum free light chain analysis, or Benz-Jones protein detection, please. Talking about the confirmatory test, it is usually the bone marrow biopsy with more than 10% of the clonal plasma cells. You'll have to consider this, please. All right. Next, we talk multiple myeloma. Very important again. Same things we discussed: osteolytic lesions or osteopenia, M spike with hypercalcemia, renal insufficiency, anemia, bone pain, constitutional symptoms, night symptoms as well. This is what you'll have to remember. Next, we talk about Waldenstrom's macroglobulinemia. Whenever there is macroglobulinemia, it is IgM because that is the largest immunoglobulin that can also lead to hyperviscosity. Whenever there is hyperviscosity, transient neurological symptoms usually present. So the patient usually has got headache, visual changes, vertigo, dizziness, ataxia. But all these last for 15 minutes to 20 minutes, something like a presentation of TIA, transient ischemic. Oh, what's TIA? I forgot. Uh, we usually do not use TIA now because we either use it as a transient neurological function is what we use. If any of my juniors say it is TIA, I consider it as
Transient
totally,
ischemic attack.
yeah, totally inappropriate assessment is what we usually use for TIA. So TIA is out of use. So I did not remember. So patients usually presenting with these symptoms mimic TIA. Transient ischemic attack is what they usually mimic. All right. Next, we talk about the physical examination. Whenever there is physical examination, examiner will give you about the retinal veins, which is usually sausage linked or dilated retinal veins in Waldenstrom's macroglobulinemia. There can be anemia, there can be increased gamma gap and increased ESR. How do you diagnose it? It is serum protein electrophoresis, where IgM spike can be seen, and the confirmatory is bone marrow biopsy, please. What are the differences between Waldenstrom's macroglobulinemia and multiple myeloma? In multiple myeloma, it is basically, in Waldenstrom's macroglobulinemia, it is basically because of IgM, whereas in multiple myeloma, it can be IgG or IgA, or it can be light chains as well. Waldenstrom's macroglobulinemia, whenever there is bone marrow biopsy, it is usually more than 10% of the clonal B cells, and in multiple myeloma, it is more than 10% of the clonal plasma cells. Whereas in Waldenstrom's macroglobulinemia, it is basically more than 10% of B cells. Multiple myeloma, it is more than 10% of clonal plasma cells. This is one thing you will have to remember, please. All right. We'll take a break for 5 minutes and then we'll come back and we'll discuss acute myeloid leukemia. Thanks very much. Welcome back, guys. Could you please let me know if you're able to see the screen? I'm able to hear my voice. Great. Welcome back. Now we'll talk about acute myeloid leukemia, where myeloid series is involved. That is why patient develop decrease in RBC, decrease in platelets, decrease in the neutrophils, which usually present as fatigue, weakness, bleeding, bruising, and infection. The lymphoid is normal, so lymphocyte can be normal or can be increased. Most commonly, it usually affects at 65 and also 35 or 45 as well. Fatigue is the most common symptom because of the involvement of the RBC. Please do remember, whenever there is bone marrow that is affected, the cell lineages involved in acute myeloid leukemia is anemia, thrombocytopenia, and granulocytopenia. If the patient has got acute myeloid leukemia, there can also be a question where the examiner can tell you that there is disseminated intravascular coagulation that classically can present as bleeding from the vein puncture sites. That is acute myeloid leukemia, acute promyelocytic leukemia. When you do a laboratory analysis of acute myeloid leukemia, there will be all cytopenias except for the leukocytes, which may be increased or can be normal or decreased if they are at the end stage. Please do remember that there is elevated lactate dehydrogenase, but the confirmatory diagnosis is bone marrow biopsy with the hypercellular myeloblast. When you do a peripheral smear, you find the myeloblast with our rods, which is the classic of acute myeloid leukemia. Next, we talk about APML, acute promyelocytic leukemia. How did I remember this? There will be increase in the neutrophil count. There will be presentation of DIC in acute promyelocytic leukemia. This is one important thing I remembered, please. All right. This is what the image looks like. Diagnosis: peripheral smear, atypical promyelocytes where large myeloid cells with intracytoplasmic violet granules that contains R rods. Cytogenetic analysis is usually confirmatory. Most of the times in hematology, it is usually the flow cytometry or electrophoresis or cytogenetic analysis that stands out as a confirmatory thing, please. If you are looking for the chromosome or gene mutation, it is usually fusion of the promyelocytic leukemic gene with the retinoic acid alpha, that is translocation 1517, is the diagnosis for APML. Complications or DAC, the treatment is all trans retinoic acid, usually promotes the differentiation of atypical promyelocytes, please. Chronic lymphocytic leukemia, this is asymptomatic, but I will tell you another question where no question banks can tell you. Usually associated with autoimmune hemolytic anemia. Only leukemia associated with autoimmune hemolytic anemia is chronic lymphocytic leukemia. Patients aged more than 75. Diagnosis is chronic lymphocytic leukemia. Patient is asymptomatic. Don't do anything, please. All right. This is chronic lymphocytic leukemia. Extreme fatigue, B symptoms, any hematological malignancy can present with B symptoms, not only CLL, but most of the times it is asymptomatic. Patient can come to the hospital and can be incidentally diagnosed to have chronic lymphocytic leukemia. It can be possibly hypogammaglobulinemia, which can cause repeated infections as well, please. Leukocytosis is often more than 100,000 per mm, please. When you do the physical examination, it is the lymphadenopathy, hepatosplenomegaly that is usually seen. How do you diagnose it? And you take a smear biopsy where you take a peripheral smear where you will find increase in the lymphocytes with the mature lymphocytes and smudge cells. Obviously, flow cytometry needs to be done, which shows monoclonal mature B cells, please. All right. Next, we talk about the complications because of the decreased immunoglobulin production. It is infection. Only leukemia that is associated with the autoimmune hemolytic anemia is CLL, please. It can also be transformed to lymphoma. Leukemias transformed to lymphoma is Richter's transformation, please. It is called Richter's transformation. Most of the times do not do anything, but the median survival is 10 years. Worse prognosis if there is lymphadenopathy, hepatosplenomegaly, and anemia and thrombocytopenia that is usually seen. Next, we talk about hairy cell leukemia. It is basically a B cell malignancy. I will have to tell you that whenever there is hairy cell leukemia, patients usually have got bone marrow infiltration, which causes bone marrow fibrosis. Please do remember, whenever there is bone marrow fibrosis, the cell needs to come out of the bone marrow. Whenever the cell is coming with the bone marrow, most of the parts of the cell is damaged. That is why patients cell usually appear as hairy. That is why it is called as hairy cell leukemia. Most of the times patient presents with bleeding, bruising, and fatigue, weakness, and all the cells are involved basically, so it can present with any of the things, please. All right, this is what a typical hairy cell leukemia looks like. Splenomegaly is the most important thing you will have to consider in hairy cell leukemia. There can be abdominal fullness, or there can be early satiety, or there can be nagging pain in the left hypochondrium that the examiner can give you, please. Peripheral blood smear, you'll obviously find lymphocytes with hairy cytoplasmic projections. What is the first most important treatment? It is the chemotherapy. Sometimes hairy cell leukemia, cladribine can be given.
Sorry,
How
can I
do you
see a picture of
diagnose?
it again? Sorry,
Yes, please.
we
Yeah.
can go back.
Hairy cell leukemia, the bone marrow biopsy can be done with the flow cytometry. So this is the picture of hairy cell leukemia.
Yes, yes. And then hairy cell leukemia is like myelofibrosis, right? You have
Yes,
the
myelofibrosis. That is why you can
but
find teardrops as well.
yeah, hairy cell leukemia is splenomegaly, not hepatomegaly.
Yes, yes. Next, we talk about chronic myelogenous leukemia. Please to remember chronic myelogenous leukemia. It is a myeloproliferative disorder with BCR-ABL gene between Philadelphia chromosome 922. I will tell you one important example or presentation. Chronic myelogenous leukemia. The examiner will tell you that a 35-year-old male patient going to Turkey or going to Europe has done a visa check normally and noticed that there is increase in the WBC count along with splenomegaly. What is your diagnosis? Massive splenomegaly is seen in chronic myelogenous leukemia. Leukocytosis may even exceed 100,000 per mm. There is thrombocytosis, there is anemia, there is absolute basophilia. What is the treatment? It is imatinib. What is the side effect of imatinib? It is nausea, please. All right. Leukemia and leukemioid reaction, we already discussed. Leukemioid reaction is leukocyte count of more than 50,000, which can cause severe infection. The most important thing in leukemioid reaction is the lab score, which is usually high. Chronic myeloid leukemia, blood WBC is elevated. There can be presence of BCR-ABL fusion gene and the lab score is low. Very important, please. If the neutrophils are actively functioning, the lab score is high. If the neutrophils are not functioning actively, the lab score is low. Very easy. If infection, severe infection, neutrophils work, lab score increases. Next, we talk about tumor lysis. You all know what tumor lysis is. I would like to tell you the abnormalities that needs to be understood. Hyperuricemia because of the spillage of nucleic acid, hyperkalemia and hyperphosphatemia because cells are the bags of potassium, hypocalcemia because of the chelation of phosphate with calcium. That is why hypocalcemia is usually seen. Tumor lysis syndrome presents within less than 24 hours, associated with malignancy, associated with initiation of chemotherapy, please. So patient can present with nausea, vomiting, whatever symptom it is, do not mind. It can present with any of the symptoms given that this patient has got hyperkalemia. Cardiac arrhythmias are usually seen, please. The patient can also develop acute kidney injury and it is possibly be because of the deposition of uric acid or calcium phosphate in the tubules. All right. What is the prophylaxis for uric acid? This thing, it is basically the IV fluids and allopurinol needs to be given, please. Rasburicase is another enzyme as well. IV fluids, allopurinol, rasburicase, and febuxostat needs to be given or stands out as the treatment for tumor lysis syndrome. Hodgkin's lymphoma, I'll tell you one classic example. There is this scientist called Hodgkins. He was examining, he was doing research on the hematological malignancies. He noticed that whenever there is any lymphoma, it usually starts with cervical, it usually involves mediastinal, it usually involves above the diaphragm, and then it involves below the diaphragm. It usually is involving in a sequential order. He named it as Hodgkin's sequence. Any lymphoma which is affecting above the diaphragm, then below the diaphragm, it is Hodgkin's lymphoma. Another pattern he noticed, it is affecting cervical first, iliac next, mediastinum next, splenomegaly. Irregular pattern of involvement, it is non-Hodgkin's lymphoma. That's it. This is what you'll have to remember. This is the concept why the chemotherapy is based on the sequential involvement of the lymph nodes. In Hodgkin's lymphoma, it usually has got bimodal distribution, painless lymphadenopathy, particularly cervical and supraclavicular. If there is mediastinal involvement, it patient can present with cough, shortness of breath, or chest pain. There can also be Pemberton sign or superior vena cava obstruction if the mediastinal lymph nodes are involved, please. Most of the times in Hodgkin's lymphoma, there can be patient developing severe pain in areas of lymphadenopathy after taking alcohol. That is one classic thing for Hodgkin's lymphoma, please. Remember, hematological malignancy present with the same symptoms. It is the night symptoms, fever, night sweats, and weight loss. It is the B symptoms, please. Pruritus can also be seen if the patient has got any release of cytokines or interleukin release, please. This is Hodgkin's lymphoma. The characteristic thing we see is the Reed-Steinberg cell. All right. Next, we talk about Hodgkin's lymphoma. Eosinophilia is usually seen. Lymphopenia and LDH can also be seen. We talked about eosinophilia in this thing. Eosinophilia usually parasites, Hodgkin's lymphoma, and Addison's disease. How do you diagnose it? This is one common question the examiner would ask you. Excisional lymph node biopsy needs to be done, and Reed-Steinberg cells are usually seen on the excisional biopsy. If there is multiple lymph node involvement, you can do PET scan to find out what are all the lymph nodes that are usually involved. And the differential diagnosis is secondary syphilis because it can also present with painless lymphadenopathy in the epitrochlear lymph nodes. Very important. Secondary syphilis, what did we discuss? Patient can present with a rash that is involving both upper limbs and lower limbs. All right. Next, we talk about Hodgkin's lymphoma treatment complications. Please do remember that with the treatment of Hodgkin's lymphoma, it can present with any of the systems that is involved, please. It can present with solid organ malignancies, it can present with cardiomyopathy, it can present with pulmonary fibrosis, bronchiectasis, chest radiation, pneumonitis, radiation therapy, or patient can present with the neuropathy from chemotherapy as well. Do not worry about Hodgkin treatment complications. It can be anything, but I want you to remember this because patients with Hodgkin's lymphoma, patients with Hodgkin's lymphoma, what happens? Patients with Hodgkin's lymphoma is usually the examiner will tell you a question that the patient has got a background of some undiagnosed cancer with the night symptoms and is started on treatment. What would be the complication? Or the examiner can give you some question saying that the patient presents with the lower motor type of neuropathy in the lower limbs. What is the thing you'll have to remember? It is basically a peripheral neuropathy that is caused by chemotherapy. Or the examiner can give you now the patient presents with the shortness of breath. Two important things you'll have to remember. One is to rule out anemia, but the examiner will tell you that the patient has recently received the blood transfusion. Then you will have to think of pulmonary fibrosis or pulmonary involvement in the patients who has got a recent lymphoma treatment. This is how an examiner can frame a question, please. Non-Hodgkin's lymphoma, you know, the sequential pattern of Hodgkin's pattern is not followed in non-Hodgkin's lymphoma. So the patient can present with painless progressive lymphadenopathy with the B symptoms. Please do remember non-Hodgkin's lymphoma is usually seen in patients who have got autoimmune disorders. So the autoimmune disorders, what happens is persistent B cell stimulation happens. That is why there can be non-Hodgkin's lymphoma. There can be immune dysregulation as well. Exposure to immunosuppressive agents can also be seen in patients with non-Hodgkin's lymphoma. Most of the times, non-Hodgkin's lymphoma are associated with the Epstein-Barr virus. Labs can show you that there is increased LDH. How do you diagnose it? It is again the excisional lymph node biopsy, which is confirmatory, please. All right. Follicular lymphoma, it is usually the 14 to 18 translocation with overexpression of BCL2 gene is what you'll have to remember for follicular lymphoma. Follicular lymphoma, The diagnosis is usually by excisional lymph node biopsy. Immunophenotyping shows translocation 14-18, and the histopathology shows nodular growth of follicular lymphocytes. Remember, follicular lymphoma is again another type of non-Hodgkin's lymphoma. So the patient can present with the same symptoms. Do not worry about the symptoms. But important thing is B symptoms are generally absent. The histopathology is usually given for you. And this is what the follicular lymphoma looks like, please. All right. Next, we talk about intravascular versus extravascular hemolysis. I'll tell you some important points about intravascular hemolysis. Please do remember, whenever there is paroxysmal nocturnal hemoglobinuria question, it is intravascular hemolysis. Transfusion reactions are intravascular hemolysis. Clostridial sepsis infections are intravascular hemolysis. Microangiopathic hemolytic anemia, it itself indicates that the hemolytic process is in the microscopic vessels. That is why it is intravascular hemolysis. Why do we need to remember this? Because the examiner can build a question around these. That is why you'll have to remember this, please. All right. Next, we talk about extravascular hemolysis. Whenever there is extravascular hemolysis, it is usually happening outside the vessel. So there can be G6PD, or there can be sickle cell thalassemia, membrane deficit such as hereditary spherocytosis, hypersplenism, warm or cold agglutinin, autoimmune hemolytic anemias. You will have to remember extravascular hemolysis, please. Hemolytic cystocytes are commonly seen in hemolytic anemia. This is what you can find. MCV in hemolytic anemia. This is one important thing you'll have to remember. Please do remember that usually whenever there is MCV, whenever there is hemolytic anemia, it is usually increased because the erythroid forms are larger, because the reticulocytes are larger. The reticulocyte count is usually increased in hemolytic anemia. That is why the MCV is usually increased. And also do remember that whenever there is a reticulocyte count that is being increased in bone marrow and decreased RBC count in the peripheral smear, it usually tries to come out. That is why the MCV is increased in hemolytic anemia, please. There can also be presence of spirocytes in autoimmune hemolytic anemia or hereditary spherocytosis. That is why MCV can also be normal or decreased. But if there are presence of spirocytes, MCHC is increased. All right. Next, we talk about paroxysmal nocturnal hemoglobinuria, intravascular hemolysis, CD55, CD59. Eculizumab is one important thing. Patient usually has got early morning hemoglobinuria. Important thing. Diagnosis is by flow cytometry, absence of CD55 and CD59 protein. I want you to understand that patient can be at risk of venous thromboembolisms, please. Patient will be presenting with early morning hemoglobinuria, hemolysis. Treatment basically is eculizumab that you will need to consider, please. All right. Next, we talk about autoimmune hemolytic anemia. You all know this, but I would like to tell you that when you find a question on jaundice, indirect bilirubin, increased serum LDH, and decreased serum haptoglobin, it is autoimmune hemolytic anemia. Most of the times, it is normochromic normocytic anemia, but the examiner can tell you that the patient has got increased LDH. You'll have to think of hemolytic anemia. It is the reticulocyte count that is usually seen. Splenomegaly is characteristically seen in autoimmune hemolytic anemia. Examiner can frame a question saying that there is splenomegaly with LDH. All right. How do you diagnose it? Diagnosis is by direct Coombs test. Now we talk about the important concept here. Autoimmune hemolytic anemia, warm and cold. All right. Males are cold, so all starts with M, please. Mycoplasma pneumonia, infectious mononucleosis is cold agglutinin. It is usually associated with IgM. That is one thing you will have to remember. Warm, warm. It is the G that you will have to remember. Anti-IgG, that is positive in warm agglutinins. Usually, drugs, viral infections, autoimmune such as SLE, immunodeficiency states, and lymphoproliferative disorders. It is warm agglutinin, autoimmune hemolytic anemia you'll have to consider. Talking about the treatment, it is basically
I
the
have a
corticosteroid.
question. Is CLL in both or mainly warm? Because I was confused about this.
Oh, CLL, it is basically uh, warm
Because some
autoimmune
places they say it's
hemolytic
both,
anemia.
but most of the time it says warm.
No, I would say warm autoimmune hemolytic anemia is associated
Okay.
with CLL,
Okay.
please. All right. Yeah, treatment is basically corticosteroids in warm and avoidance of cold temperature in cold agglutinin, please. All right. Complications are usually venous thromboembolism and progression to lymphoproliferative disorder, whereas cold agglutinin they can cause ischemia or peripheral gangrene with the lymphoproliferative disorders that needs to be understood, please. All right. Next, we talk about hereditary spherocytosis. Whenever there is hemolytic anemia with jaundice and splenomegaly with raised MCHC, that is diagnosis of hereditary spherocytosis. Treatment is folic acid supplementation, blood transfusion, and splenectomy. Sometimes there can be this question or a clue that can be asked in the question. There is abnormal eosin 5 malamide binding test that needs to be given. Examiners would not give you increased MCHC, rather than they can give you negative Coombs test with jaundice, hemolytic anemia, and splenomegaly. It is hereditary spherocytosis until otherwise proved, please. All right. Next, we talk about hereditary spherocytosis versus autoimmune. Autoimmune, it is positive Coombs test, whereas MCHC, it is negative Coombs test. Sometimes MCHC can be increased in both hereditary spherocytosis versus autoimmune, but negative Coombs test is seen in hereditary spherocytosis. Positive Coombs test is seen in autoimmune hemolytic anemia. Positive family history is hereditary spherocytosis because it is autosomal dominant. Positive osmophragilic test is seen in hereditary spherocytosis as well, please. Hemolytic anemia due to artificial valves, the examiner will be talking about heart failure, replacement of the heart valve in replacement of heart valve in patients with valvular disorders. And now the examiner will tell you that the patient is presenting with shortness of breath where you've got cystocytes on peripheral smear. It is hemolytic anemia until otherwise proved, please. The examiner can also tell you that the valves replaced or mechanical valves. Whenever there is mechanical valve involvement, it is hemolytic anemia that is usually seen, please. Next, we talk about the thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura is basically because of the decreased Adam 13 level, where there will be von Willebrand factor in multimers, which causes platelet activation and also platelet trapping. This basically leads to hemolytic anemia and thrombocytopenia. Sometimes the examiner can also tell you there is renal failure, neurological manifestations, and fever, which is usually the pentad. Management is plasma exchange needs to be done, please. This is one important question the examiner wants you to remember, because this is an emergency. The patient can present with hemolytic anemia, and the patient can be presenting with shortness of breath, or there can be bleeding that's been going on. That indicates that the patient can be having thrombotic thrombocytopenic purpura, and in TTP it is the plasma exchange we will have to consider, please. G6PD deficiency, we have already discussed that patients can be presenting with the ingestion of fava beans or dapsone presenting with hemolysis, where you can find Heinz bodies and bite cells, please. How do you treat it? You'll have to remove the risk factor or the triggering factor and provide supportive care, and the examiner can tell you that the patient can be having dark urine. What is the next best step? To not do anything, stop the offending medication, stop the fava beans and stuff. Examiner would ask you, when do you check the G6PD levels? It is usually after the attack has been resolved. So G6PD levels can be normal during the attack. This is one important thing you'll have to remember. It is usually 6 weeks after the attack we check for G6PD. What are the medications that trigger hemolysis in G6PD? Dapsone, isobutyl nitrate, nitrofurantoin, primaquine, and rasburicase. Most often, it is the nitrofurantoin and the dapsone that the examiner can ask you, please. All right. You need not remember that. Pyruvate kinase deficiency, we'll talk more about pyruvate kinase deficiency in pediatrics as well. Pyruvate kinase deficiency is autosomal recessive. Most of the times, enzyme induced hemolysis, they are negative. Okay, presentation is chronic hemolysis with hepatosplenomegaly, skin ulcers, and pigmented gallstones. The differential is G6PD deficiency. Whenever there is a G6PD deficiency, it is basically an inciting event or the drug abuse or something is present. Whereas in pyruvate kinase deficiency, it is always the chronic constant hemolysis that is going on. If the patient is a young patient, it is pyruvate kinase. If the patient is like teenage or adult patient after some ingestion, it is G6PD deficiency. Very, very, very important, please. Pyruvate kinase, there is hemolysis going on. Chronic hemolysis can be seen. There can be hepatosplenomegaly, there can be skin ulcers, there can be pigmented gallstones. All these point towards pyruvate kinase deficiency or chronic
Can
hemolysis
you,
signs, please.
sorry, explain why there's pigmented gallstones here again?
Basically, the patient has got chronic hemolysis, the heme,
Mhm.
bilirubin, and everything is broken down. That is why the gallstones are formed, please.
Is this biliary stasis going on, right?
Delayed stage is going
Because
on, and the
ATP is
heme,
linked to CCK, right?
yes,
With the
that's right.
contraction.
Yeah, yeah.
Yeah.
And the heme
Can I
gets
see the previous
deposited.
picture, if you don't mind also? I'm sorry.
Yeah, hemoglobin usually gets deposited in the gallstones. That is why pigmented gallstones, and basically pigmented gallstones are usually seen in hemolysis as well. All right, so constant hemolysis, whenever there is going on, there is pigmented gallstones, please remember. Pyruvate kinase deficiency, there will be constant hemolysis, whereas in G6PD deficiency there is only inciting event or a triggering event usually seen, please. Sickle cell disease, we already discussed. There will be autosplenectomy by the adulthood, and painful vasocrisis needs to be addressed and usually seen in children, please. Pernicious anemia, basically because of the antibodies that are developed towards the anti-intrinsic factor antibodies. Whenever there is intrinsic factor antibodies, they usually decrease the amount of the functional intrinsic factor, causing the absorption of vitamin B12 to be decreased. Sometimes pernicious anemia can also be manifested as chronic atrophic gastritis that can also lead to decreased production of intrinsic factor by the parietal cells. There can be parietal cells antibodies against the parietal cells, please. That is why it can manifest as chronic atrophic gastritis leading to intrinsic factor deficiency. Pernicious anemia usually presents as macrocytic anemia with mild thrombocytopenia, with leukopenia and shiny tongue. Very, very, very important, please. Subacute combined degeneration needs to be understood if the patient is being treated only with if the patient is being only treated with vitamin B12 deficiency, please. So correct folate as well. What are the complications? Gastric cancer is one important type, one important thing you will have to remember for pernicious anemia. All right. Next, we talk about hemolysis to vitamin B12 deficiency. Please do remember, whenever there is vitamin B12 deficiency, it leads to ineffective erythropoiesis. Whenever there is ineffective erythropoiesis, there will be megaloblasts that are increased, and this megaloblast usually break down, and this megaloblast release heme, which is converted to indirect hyperbilirubinemia. Hemolysis also causes the LDH that needs to be increased, so total RBC count and reticulocyte count is usually decreased. Very, very, very important, please. So hemolysis can also be seen in vitamin B12 deficiency because of the ineffective erythropoiesis and accumulation of the megaloblasts, and these megaloblasts usually cause hemolysis, which releases heme, and that can cause hemolysis of RBC and also reticulocyte count, please. Next, we talk about the normal RBC count in vitamin B12 and deficiency. Sometimes patients can present with vitamin B12 deficiency only with the neurological functions. This is mostly the real scenario which we usually see, please. All right. Next, we talk about causes of thrombocytopenia. Anything can cause thrombocytopenia, but you will have to understand what is the mechanism that the thrombocytopenia is caused. Could it be because of the decreased platelet production, or could it be because of the increased platelet destruction? That is the important thing you'll have to remember. First, we'll see the decreased platelet production. Whenever there is bone marrow problem, or whenever there is something that is not actually giving good strength to the bone marrow, it causes a decreased platelet production. Infections, chemotherapy, cancer, alcohol use, Fanconi syndrome, and vitamin B12 or folate deficiency causes platelet production. Congenital is one important thing you'll have to remember, but they won't ask you. They will just give you an option on as a Fanconi syndrome. Viral infections such as Epstein-Barr virus, hepatitis C, HIV, chemotherapy, myelodysplasia, alcohol use, congenital such as Fanconi syndrome, vitamin B12 or folate deficiency, you'll have to consider decreased platelet production. Now we will see increased platelet destruction. Whenever there is increased platelet destruction, it indicates that the bone marrow is functioning well, but there is some problem in the peripheries. Whenever there is some problem in the peripheries, it is usually autoimmune. So SLE, medications, idiopathic thrombocytopenic purpura, and antiphospholipid antibody syndrome. You need not remember all these causes. Just remember there is something outside the bone marrow, but the bone marrow is fine. So obviously autoimmune disorders are one important thing you will have to remember, please. Obviously, other causes of thrombocytopenia, when we say, it is the splenic sequestration, which is usually the painful abdomen the examiner can give you, and dilutional. Whenever there is dilutional, it is usually increasing the it is usually giving the increased IV fluids or massive red cell transfusions that can happen. All right. Next, we talk about indications of platelet transfusion. Please take a screenshot of this. The examiner will certainly ask you on this. If platelet count is less than 10,000, it is an indication for platelet transfusion. If platelet count is less than 50,000 with active bleeding, this is what you'll have to remember. With active bleeding, it is indication for platelet transfusion. All right. I'll take a break for 5 minutes and then I'll continue the session. Thank you. Welcome back. Now we'll talk about immune thrombocytopenia. Whenever there is a question on thrombocytopenia, please do remember that there is associated mucocutaneous bleeding, or there can be ecchymosis, or there can be petechiae or purpura. This is what you'll have to remember. Immune thrombocytopenic purpura is basically because of the
Sorry, can you
antibody
share your
form.
screen? We're not seeing anything.
Thank you for letting me know. So now we'll talk about immune thrombocytopenia. Whenever there is immune thrombocytopenia, there is mucocutaneous bleeding, or there can be ecchymosis, petechiae, purpura. Usually, immune thrombocytopenia is basically because of the development of the autoantibodies with the recent viral infection. This is what the examiners will give you the clue. HIV, HCV, or there can be chronic lymphocytic leukemia as well. Most of the times auto antibodies are formed. How do you do the diagnosis? Immune thrombocytopenia is usually a diagnosis of exclusion, so you'll have to do all the blood tests which shows completely normal. But if the patient has got HIV or HCV, immune thrombocytopenic purpura can be seen. Immune thrombocytopenia can be seen, please. The treatment is you'll have to observe if there is no bleeding or if the platelets are more than 30,000. But if the patient has got platelets of less than 50,000 and is associated with bleeding, you'll have to transfuse it. Corticosteroids play an important role because of the formation of antibodies that stands out as the pathophysiology. Sorry, IVIG and platelet transfusion needs to be done if there is hemorrhage. This is one important thing you'll have to remember. Please to remember that there is normal liver and normal spleen in patients with immune thrombocytopenia. All right. Next, we talk about. So this is what we discussed. Next, we talk about pseudothrombocytopenia. Pseudothrombocytopenia is basically because of the clumping, and this clumping happens because of the serum antibodies that are developed to EDTA or abciximab administration, or there can be inadequate anticoagulation. Very important, these three questions or three scenarios can be tested in USMLE. It can be caused by the platelet clumping because of the formation of serum antibodies, or it can be abciximab administration, or there can be inadequate coagulation. This is what you'll have to remember, please. All right. Next, heparin-induced thrombocytopenia. What did we discuss? Venous plus arterial clot is one important thing. The examiner can tell you that the patient is recently admitted to the hospital and is started on heparin. Now presents with the examiner can talk to you about DVT, or the examiner can talk to you about the platelets, antibodies to platelet factor 4, or the examiner can talk to you about any of the pulmonary embolism or myocardial infarction. Please do remember, heparin-induced thrombocytopenia is usually seen with an inciting event of starting heparin. The examiner can talk about type 1 hit or type 2 hit, which is usually the step 1 question. I'm not worried about it, but one important thing I will have to tell you is in type 1 hit, thrombocytopenia is usually mild, and type 1 hit usually happens in the first 2 days of heparin exposure, whereas type 2 hit is basically presenting with the platelet aggregation, so there will be thrombocytopenia and there can be thrombosis as well, please. All right. And type 2 heparin induced thrombocytopenia is usually from 5 days to 10 days, or you can remember more than 1 week, or as a late presentation. This is what you will have to remember. How do you diagnose it is the question. Diagnosis is by serotonin release assay, which is the gold standard, and there can also be high titer immunoassay, but serotonin release assay is what the examiner will ask you. All right. How do you manage this patient? You'll have to discontinue the heparin immediately, and then you can give a direct anticoagulant or direct thrombin inhibitor. Argatroban can be given direct thrombin inhibitor, please. Or fondaparinux can also be given, but I would like to go with argatroban, please. All right. Next, we talk about von Willebrand disease. I would like to tell you that if the examiner is talking about a female patient with the bleeding disorder, it is von Willebrand factor disease. If the examiner is talking about a male patient with bleeding disorder and family history, it is hemophilia. Von Willebrand factor will also have family history, but if the patient is female, it is von Willebrand factor. If the patient is male, it is hemophilia. Von Willebrand factor, talking about von Willebrand disease, it is autosomal dominant. It is because of the impaired quantity or activity of von Willebrand factor. So patient can present with mucosal bleeding, easy bruising, and skin bleeding. Personally, I remembered it as BAV. Bleeding time and APTT is increased in hemophilia. Whereas, bleeding time and APTT is increased in von Willebrand disease with the normal PT. Talking about hemophilia A and B, we all know that it is X-linked recessive. Patient can present with hemarthrosis or gastrointestinal hemorrhage, but hemophilia, it ends with A, so there will be increased APTT. That's it. This is what I have remembered. Hemophilia, increased APTT, absent factors, factor 8 in hemophilia A and factor 9 in hemophilia B. Treatment is factor replacement, and you can use desmopressin for mild hemophilia. This is one important thing you'll have to remember. Next, we talk about lupus anticoagulant. Whenever there is a patient who has got increased APTT, what is the next best step? You repeat the APTT after 3 months. Yes, after 3 months also there is increased APTT. What do? Just check antiphospholipid antibodies. That is one thing you will have to remember, please. All right. Elevated PT or APTT in patients with hemophilia, elevated APTT, repeat after 3 months. If patient has got increased APTT after 3 months, check antiphospholipid antibody syndrome. Very important, please. All right. Now we talk about other things. Patients with development of inhibitors, elevated PT or APTT is usually seen. And now you will have to do 1:1 inhibitor mixing study if the patient has got hemophilia not responding. Then, if the inhibitor mixing study corrects a normal PT or APTT, it is basically the factor deficiency and evaluate for individual factors. If it does not correct the abnormal PT or APTT, inhibitors likely present. All right, so test for anticoagulation factors, please. Antiphospholipid antibody syndrome. The clinical symptoms are vascular thrombosis, arterial and venous thrombosis, and patients usually present with more than 3 consecutive pregnancy loss with unexplained fetal losses, with more than one unexplained fetal loss after 10th week, please. Lab studies usually seen are lupus anticoagulant, anticardiolipin antibodies such as IgM or IgG or IgM with high titer, and anti-beta 2 glycoprotein anti-1 antibody can also be seen, please. Lab studies are important because the examiner can talk about any of the antibodies. Please do remember it is the lupus anticoagulant, anticardiolipin antibody, anti-beta 2 glycoprotein 1 antibody as well. Antiphospholipid syndrome is usually diagnosed in a female patient presenting with the recurrent pregnancy losses, or can also be presenting with vascular thrombosis such as arterial thrombosis and venous thrombosis. Antiphospholipid antibody syndrome is another example. What all did we discuss today? Paroxysmal nocturnal hemoglobinuria, homocystinuria, HIT syndrome, polycythemia vera, and antiphospholipid antibody syndrome can present with both arterial and venous clots, please. Next, we talk about immune transfusion reactions. Please to remember this is very easy. Anaphylactic, usually within seconds, associated with wheezing. Most of the patients are IgA deficient. Acute hemolytic anemia usually develops within 1 hour because of the ABO compatibility. If you think that the patient has got hemolytic anemia, patient must have flank pain and hemoglobinuria. Febrile non-hemolytic reaction, continue the blood transfusion with giving paracetamol. Patient develops fever and chills after starting transfusion. So continue the blood transfusion by giving paracetamol. Don't do anything else. Transfusion related acute lung injury. Usually lung injury is seen. So respiratory distress and non-cardiogenic pulmonary edema is seen. In step 1, it is asked donor anti-leukocyte antibodies are usually present. Delayed hemolytic reaction, I will tell you that the positive Coombs with asymptomatic after transfusion is delayed hemolytic. Graft versus host disease, you will have to consider rash, fever, GI tract. But what did we discuss in the previous lectures? We need to rule out cytomegalovirus. Last thing is recipient IgE reaction can develop urticaria, please. It usually develops within 2 to 3 hours with the presence of urticaria. That's an urticarial sign, please. All right. Next, we talk about delayed hemolytic transfusion reaction. Obviously, more than 24 hours, and there will be positive Coombs. Please do remember that positive Coombs is seen only after the transfusion in delayed hemolytic. Previously, he is negative for Coombs. This is one thing the examiner can give you, please. Before transfusion, this is transfusion. After transfusion, he'll be positive Coombs. Before transfusion, he is negative Coombs with absent symptoms, or sometimes a patient can present with hemolytic anemia. This is delayed transfusion reaction. Don't do anything, please. You just do the supportive management, please. That's it. All right. Next, we talk about blood transfusion reactions associated with hypotension. Anaphylaxis, you'll have to think of these, please. Transfusion related lung injuries, there is non cardiogenic pulmonary edema. Primary hypotension reaction can develop, but please do remember, if there is primary hypotension reaction, it must be immediate, please. Within minutes of transfusion, that is because of the bradykinin in the bloods. All right, bacterial sepsis. Bacterial sepsis is usually seen with platelet transfusion. Obviously, whenever there is sepsis, there will be decreased blood pressure and there will be fever, chills, and septic shock, please. All right, next we talk about post-transfusion anaphylaxis. Post-transfusion anaphylaxis usually happens in patients who have got IgA deficiency. Why does it happen? It happens because the presence of IgG antibodies that are present in the donor cells. Remember, the patient can develop anaphylaxis is basically wheezing and hypotension with involvement of mucous membranes, angioedema, respiratory distress, and systemic involvement as well. What do? You'll have to stop the transfusion, give intramuscular epinephrine, antihistamines, and glucocorticoids. What are the differentials? The ABO mismatching. Remember, it is the flank pain that needs to be considered if you are thinking of acute hemolytic reaction. So, acute hemolytic reaction is a differential diagnosis. All right. Next, we talk about febrile non-hemolytic transfusion reaction. Do not do anything, please. Just continue the transfusion reaction, please. Just continue the transfusion and give him some paracetamol. Next, we talk about hemolytic blood transfusion reaction. Acute hemolytic transfusion reaction usually presents with flank pain. Whenever there is flank pain, it indicates that there can be hemoglobinuria. It usually leads to renal failure and DIC. There will be Coombs test that is positive with the plasma-free hemoglobin of more than 25
Sorry,
milligram
can I
per
see the
liter.
previous slide for the FNHTR again? Was there an
Yeah,
FNHTR?
febrile,
Can you
no,
cover this? Yeah.
there is nothing. Febrile non-hemolytic transfusion reaction, the examiner will tell you that the patient has only got temperature. That's it. No other things will be given, please. All right. So you'll have to consider that it is a febrile non-hemolytic transfusion reaction. Whenever there is hemolysis, it usually causes flank pain, but there is no flank pain, no systemic signs. It's only the fever without hemolysis is febrile non-hemolytic transfusion reaction.
This is due to
Stop.
cytokines.
Yes, it is because of the cytokines, please.
Mhm.
All right. Next, we talk about, yeah, this is important, please. Indications for specialized RBC treatment. Where do we use irradiated transfusion? It is bone marrow transplant patients, patient with congenital cellular immunodeficiency. Whereas leukoreduced RBCs is used in chronically transfused patients. Very important, please. Patients with the transplants, leukoreduced RBC needs to be given. Where do we use washed RBC? This is important. It is given in IgA deficiency. And you can also give this patient, you can also use washed RBCs in patient who has got complement dependent autoimmune hemolytic anemia and allergic responses, continued allergic responses such as urticaria. All right, these are the things you'll have to remember, please. Graft versus host disease, usually seen in bone marrow transplant patients. It is basically because of the activated donor T cells against the host major and minor HLA antigens. If there is graft versus host disease, please do remember that there can be skin findings, maculopapular rash involving palm, soles, and face. There can be blood positive, that is diarrhea. That is the reason we usually rule out CMV. And you will be surprised to see that the examiner will tell you that CMV is negative just to make sure that you answer graft versus host disease. There can be abnormal LFTs and also jaundice. All right. Transfusion transmitted bacterial infections. Please do remember that it is basically because of the platelets that the patient has developed the bacterial infection. Whenever there is bacterial infection, patient presents with fever, tachycardia, and hypotension. All right. Next, we talk about hypercoagulability secondary to increased homocysteine levels. All right. What happens whenever there is increased homocysteine? Why does the patient develop hypercoagulability? We already discussed that this causes both venous thrombosis as well as arterial thrombosis. This is basically because of the direct vascular damage, activation of the clotting mechanisms, and inhibition of the antithrombin pathway. What is the treatment you need to do? It is the pyridoxine and the folate you need to give in patients who have got hypercoagulable state because of the increased homocysteine, please. All right. Next, we talk about disseminated intravascular coagulopathy. I would like to tell you that whenever there is bleeding from the vein puncture sites, it is disseminated intravascular coagulation until otherwise proved, please. The coagulation is intravascular and is disseminated. So most commonly, it is seen in patients who are very ill, such as in patients who have got sepsis or severe trauma or obstetric complications. Acute DAC, the patient will have platelets that are low, fibrinogen that is low, but D dimer is high, and the bleeding risk is very high in disseminated intravascular coagulation in acute cases. That is why the patient usually develops bleeding from the vein puncture sites, please. All right. All the clotting factors are used up. So coagulation studies are usually prolonged. All right. Chronic DAC is seen in malignancy. That's it. That is the learning point you will have to remember. Everything else is normal. It is only the bleeding risk that is mildly increased. Obviously, if it is a DAC, it is usually the D dimer that is increased in DAC, please. All right. Next, we talk about carbon monoxide poisoning. The only reason I've put the carbon monoxide poisoning is patient who has got carbon monoxide poisoning can present with myocardial ischemia. Very important. Obviously, it is defective heating systems, gas motor operations, and everything else. You can find it. It is headache, confusion, malaise, dizziness, nausea, if the patient has got mild carbon monoxide poisoning. If it is a severe carbon monoxide poisoning, patient can develop myocardial infarction, ischemia, and arrhythmia. The diagnosis of carbon monoxide poisoning, you'll have to do an ABG and identify the carboxyhemoglobin level with the ECG and cardiac enzymes as well, please. Treatment is you'll have to consider high flow 100% oxygen. We discussed before we starting the session carbon monoxide poisoning or any poisoning or anything in medicine, you'll have to make sure that the patient is safe. That is why airway needs to be maintained, please. All right. High flow 100% oxygen needs to be given, and intubation and hyperbaric oxygen can be given if the patient has got severe carbon monoxide poisoning. All right. Next, we talk about aplastic anemia. Every cell is affected. Aplastic anemia, there is pancytopenia, there is no splenomegaly, there is no reticulocytosis with the normal cellular morphology, please. Or whenever the examiner is talking about a patient with aplastic anemia, the examiner wants to tell you that the bone marrow is gone. Bone marrow is gone because of the autoimmunity, because of the infections such as Epstein-Barr virus. Most common and favorite virus is parvovirus B19. The examiner can tell you that radiation is one of the underlying clue for aplastic anemia, please. All right. So pathogenesis is basically bone marrow failure because of autoimmunity, infections, drugs, and exposure to radiation or toxins. When you do a clinic or lab study, it is the pancytopenia that we usually see, and patients is pancytopenic, so obviously fatigue, weakness, and pallor if RBC is decreased, mucosal bleeding, easy bruising, and petechiae if thrombocytopenia is seen, and recurrent infections if there is leukopenia. What do you
Oh,
do?
sorry.
What do you do?
Can I see the previous one with the causes? You had a list of causes.
Yes,
Can
please.
you
Yeah.
go over this again, this page?
Yes, please. Yeah. So basically, the examiner will give you a clue of bone marrow failure. Whenever there is bone marrow failure, there must be an inciting event to cause the bone marrow failure to result it in a aplastic anemia. Sometimes it is basically because of the CD34 stem cell deficiency as well. But aplastic anemia is mostly induced. So autoimmunity, infections such as parvovirus B19 and Epstein-Barr virus. Parvovirus B19 can cause aplastic crisis. Drugs such as carbamazepine, chloramphenicol, sulfonamides can cause aplastic anemia. Radiation can also cause aplastic anemia, please. The lab findings, obviously, it is pancytopenia. So, anemia, thrombocytopenia, and leukopenia is seen. Whenever there is anemia, patient presents with fatigue. Whenever there is thrombocytopenia, it is the bleeding disorders. Whenever there is leukopenia, it is the recurrent infections which we usually see. Given that the bone marrow is completely lost, when you take a biopsy, it is the hypocellular bone marrow with the fat and the stroma cells that is usually seen, please. All right. Next, we talk about myelodysplasia. There is dysplasia of the myeloid cells. So the patient can, there is dysplasia in the bone marrow. So the patient can present with again pancytopenia, that is macrocytic anemia, thrombocytopenia, and leukemia. When you do a blood smear, it is dysplastic granulocytes that are hypogranulated and hyposegmented, that is usually seen in myelodysplasia, please. It is called as Pegler Hute cells. Pegler Hute cells is dysplastic granulocytes that are hypogranulated and hyposegmented, please. All right. Next, we talk about, that's it. This completes our hematology. Thank you for joining. I'll see you in the next session.
Thank you.
Thank you.